Welcome everyone to ProHealth One's October webinar, Wound Care with Comfort in Mind, a Palliative Care Approach. Thank you for taking the time to join us for this educational session, especially around your lunchtime. We always appreciate your company. My name is Johanna Welch. I'm a Wound Care Certified RN and Ostomy Management Specialist, as well as Assistant Director of Clinical Services for ProHealth One, and I'll be one of the panelists for today's webinar. A quick note before we get started, please use the question and answer box on the side to ask any questions throughout the presentation, and we'll be addressing those at the end of the presentation. Also, we have polling questions throughout the webinar today, and in order to get credit for the continuing education hour, please make sure to respond to all of those polling questions and attend the entire presentation. Okay, next. Okay. For the record, this is for educational purposes only. Please consult the appropriate healthcare professionals for medical advice. ProHealth One is not affiliated with, sponsored by, or receiving compensation from any of the companies or brands mentioned in this presentation. Any references to specific products are for informational only and do not constitute as an endorsement. All products, names, and trademarks belong to their respective owner. Okay. So today our objectives are for participants to be able to identify common palliative wounds and understand their underlying causes, as well as differentiate between curative and palliative wound care. Participants will learn practical approaches to palliative wound management and increase their communicative skills while discussing goals and incorporating patient-centered values for this specific population. So without further ado, I'd like to introduce our speaker today, Dr. Pradeep Raj Rai. Dr. Rai is our wonderful owner, founder, CEO, medical director, and an actively practicing wound care physician for ProHealth One. So a big thank you to him for taking the time out of his busy schedule to be here today. So I'll pass it over to him. Dr. Rai, take it away.
Thanks, Johanna. Can you all hear me okay?
Yep.
So thank you all, like Johanna said, for taking the time. I know most of you, from what I saw from the sign up list, are here in the mountain area, so you're probably having lunch. And as you all know, there'll be a lot of slides here and sometimes pictures. And I know you wouldn't be joining if you didn't join for the pictures. So we've included quite a few very interesting slides. Some of them we may have used in a prior presentation, but they are impactful. So this topic is a really important one and kind of a broad one in some ways because there's a lot of confusion when it comes to how to take care of wounds that are in our eyes, our wounds, we love to see one simple result, and that result is we want to see them heal, right? That's our ultimate goal with our wounds. And then, of course, we never want to see them come back. But in the case of palliative and hospice care in particular, those are two terms that are used somewhat interchangeably at times. And so what I'll start out with, and I probably won't necessarily read like every word from these slides. I don't like to do that. I'll just kind of talk a little bit and know that if I don't say it specifically on the slide, I'm covering it at some point during the slide. So there's a distinction between palliative care and hospice care. Some of you may or may not know what that is. So hospice care in particular are patients who have a terminal illness that have been designated to have 6 months or less to live. Now, obviously, that may not happen within 6 months, but sometimes you may see them when there's a day left to live, or there are 2 months left, or sometimes even longer than 6 months. But you have this estimate in your head as a hospice provider that, okay, they have a terminal illness, whether it be cancer or some sort of end stage disease, or senile degeneration like Alzheimer's or something like that. And so you have this idea in your head and you say, okay, well, they've got this amount of time to live, and based on what we know about that disease process, they're going to live for X amount of time. And then you have the palliative side. Now, the palliative side is a little bit different. Some people think they're the same thing. Palliative is basically telling you that palliative care, they're still followed by a community provider, primary care provider. And that community primary care provider is essentially coming in and still managing their primary care, but they have some kind of a terminal disease process that may require specific attention. And so the palliative provider may come in and just provide that extra little bit of support And then when they transition, they may not even be eligible for hospice. They may not even want to be on hospice, but they still want to maybe even seek treatment. So there's a distinction between palliative care and hospice care. And so goals are basically, very different, I would say, when it comes to a straightforward person or a patient who has a wound versus someone who's on palliative or hospice care. So moving forward, we'll talk about palliative wound care. Now, what does palliate mean? Palliate really means to make a disease or a symptom less severe or less unpleasant without removing the inciting cause. So I mentioned things like cancer or some sort of end stage disease. And, we take that and we say, okay, they've got a wound, and we're going to try to do the best that we can. And I'll kind of highlight some slides as we go through this that you want to try to remember or even jot down. Or if you ever want to, of course, go back and watch this, we do have a YouTube channel where you can go ahead and take a look at it again. But there's a couple of slides on here that I would like for you to just kind of focus on. I'll bring those to your attention when they happen. Um, there is a question here that we're going to pull for everybody, and I'll read it for you. How familiar are you with palliative wound care management? And so I'll give you about 60 seconds to answer that question. And once again, Johanna mentioned that everybody who's trying to get credit for this has to respond to all the poll questions. So I'll go ahead and let you take a second and answer these real quick. So how familiar are you with palliative wound care management? Are you very familiar, somewhat familiar, kind of heard of it, but not really confident, or not familiar at all? Okay. So results of that poll, somewhat familiar. Most of you are somewhat familiar, and a few of you are very familiar. Some of them not very confident. So hopefully this talk today can help educate you a little bit more for those of you that are not super familiar with it, and I hope to give you a little bit more of a bigger scope for your wound care needs and how you address your patients. So once again, palliate. What does it mean? It means to, once again, make a disease or a symptom less severe or less unpleasant without removing the inciting cause. And once you go back to the definition that I gave you earlier, the distinction between palliative and hospice care and what those mean. So, when somebody has a terminal illness, whether it be cancer, senile degeneration like Alzheimer's, or some sort of end stage organ dysfunction, you know that there's not really perhaps a cure, especially when they're on hospice. And so you're not necessarily trying to get rid of the actual cause, but you are trying to make the symptom or whatever disease process a little bit less severe. So sometimes that can mean pain control, and that may just be wound care. So that's what we're going to focus on today. Looking at the overlaps that happen. So there's terminology here that you can see on this page that goes over an array of skin injuries that can happen, whether they be in palliative care or in hospice care. So once again, that overlap is going to exist. And we're going to go through each of these, whether it be a Kennedy ulcer, scale wounds, skin failure, the TBTTI, Trombley-Brennan terminal tissue injuries. That's the last time I'm going to say that whole thing all at once. I'll just abbreviate to TBTTI. And then the fungating malignancy. So all these terms are very relevant when it comes to patients that are either in palliative or hospice care. And so we'll talk about how to approach them, what their etiologies are. First one I'll start with is a Kennedy ulcer. The Kennedy ulcer a lot of people don't know, it actually comes from the name of somebody who presented at a conference at the NPUAP back in 1989. No one really knows what the etiology is of these wounds. Pressure could, of course, be an inciting factor. A little bit more research was done into these during COVID and some of the skin changes that happened during COVID. And there are some specific changes that are separate to COVID. We won't go into those today. But some typical Kennedy ulcer characteristics. There can be a variety of different colors. Shapes that I have typically seen are more of like a butterfly or a horseshoe shaped ulcer. They typically have very irregular borders. They're very sudden in onset. They're typically located on bony prominences like the sacrum, the coccyx, the hips, the heels, or the buttocks. Um, so typically they'll present very, very superficially. You'll look at them like, this looks kind of weird. Maybe they were and they slid down the bed or something, and then you suddenly see a very big change that happened. And they can happen in a couple of different ways. The most common presentation, some that happens more bilaterally. The second one is where it's more of a unilateral, just kind of like a dark intact spot that develops rapidly within 24 hours. And sometimes when that happens, the patient will typically pass away within about a day or so. Um, and then I mentioned they progress very rapidly. So they'll typically look, if you look at the image on the left there, that's a very common presentation. If you kind of look at that sideways, it looks sort of like a butterfly. And you see some purple, you see some DTIs within the wound bed, that kind of purple area at the bottom there, if you can see my cursor. And then within about a week, they progress very, very quickly to a much more advanced, typically a stage 4 is what you're going to eventually see. If you actually get down to viable structures, you'll find that this goes very quickly and goes down to muscle or bone fairly fast. So, and usually these patients, and we get this question so often, is they'll identify a wound, a nurse will identify a wound, or a provider will identify a wound, and they'll call us like, hey, can we call this a Kennedy? And technically speaking, you really can't call something a Kennedy until the patient has actually passed away. So I certainly always appreciate the question, but really you can't say for sure because sometimes patients will develop a wound, and we'll talk about why that's so significant when we talk about skin failure and scale. So once again, this is a little bit of a closer up of what we just showed you, week 1 to week 2, and how quickly it can progress from one to another. And then week 3, you can see all this obstructive tissue that is obstructing the wound bed itself, and you've got a significant amount of slough and necrotic tissue present there. So Kennedy ulcers, the debate, can you actually diagnose a wound until after the patient passes? In my eyes, you cannot, because you don't actually know whether or not the actual wound is going to pass, or the patient's going to pass away. I mentioned the pressure component to it as well, and there's some controversy whether it's just hyperperfusion or just a natural process of dying. So we can label that technically as skin failure, but there are various stages of skin failure that we're going to jump into here. So skin changes at the end of life, otherwise known as scale. So I'll kind of jump into a little bit of a sidebar here because there's so many components that go into effect when we get to the end of life. Excuse me one second. So let's think about it on a global standpoint. Like take a step back from the palliative and the hospice standpoint that we've been talking about. And let's just talk about a wound and then the nutrition that goes along when a patient develops a wound. So when a patient has a wound, the body basically triggers catabolic state, right? So that response starts to break down the body's own tissue to meet the demands of healing, right? So if you're taking in a normal amount of calories a day, 1,800 to 2,100 calories a day, and then you suddenly develop a significant wound. That changes because the body is now trying to fight that wound. It's trying to actually catch up with the needs of the body because the body actually is innate in the fact that it wants to heal that wound and get it better, right? So if you think about that and you're just eating a normal caloric amount of taking a normal caloric intake during a day, and that typically is about 20 to 25 kilocalories per kilogram. A patient with a wound can require 10 more than those, so 30 to 35 kilocalories per kilogram, or sometimes even more. And so if the patient's nutritional intake does not meet the increased demand, the body will continue to break down its own resources. So if you're not getting enough protein intake, your body's going to say, well, we got to get this from somewhere. So it's going to start breaking down its own stores. And so what happens then is you get protein breakdown. The body's hormonal balance then shifts and it favors catabolic state versus anabolic state. Anabolic meaning it's trying to build back up. So your hormones like your cortisol, your glucagon, and your catecholamines will go up. And then the anabolic hormones like insulin and growth hormone become less effective. You typically will then see muscle wasting. The hormonal imbalance triggers the breakdown of muscle and other tissue that you need where there are amino acids to make new tissue, to make new proteins. So there's a significance of lean body mass. And so when that lean body mass starts to dip and dip and dip, your immune defenses start to go down. You have poor wound healing, and you have an increased risk of complications like pneumonia and kidney injury and things like that. So I bring up scale because it is typically at the end of the dying process. And I mentioned the homeostatic changes that occur. And so major complications can arise just from the smallest insults. So organ dysfunction, I mentioned that. Obviously, the skin is the largest organ, but you can have other organs that can become dysfunctional. There are risk factors that are involved here. Hypoxia, we know that that's obviously a very significant one. You have shunting of blood away from tissues like the skin to your more vital organs, your heart, your brain, your lungs, those things, and so your kidneys. So the ability for the body to really prioritize in some ways is that we want to preserve the heart, we want to preserve the kidneys, the brain, and what gets compromised? The skin gets compromised, right? So some of this can also come from poor nutrition or poor intake, limitation in mobility, incontinence, and those are just a few, of course. So skin failure, a little bit different. This can happen really at any time, if you're in a disease process. So just because you have skin failure doesn't mean that you're at with scale, right? So if you have skin failure, this can happen because you're in the ICU for X amount of days and you're fighting a bunch of other things. So the same kind of processes happen. You're fighting something acute or even something chronic, or it could be actually part of the dying process. We don't know yet, but it does not have to be at the end of life. So moving forward to, I said I wouldn't say the name again, but I'll say it one more time, Trombley-Brennan terminal tissue injuries, TBTTI. Try to say that 5 times real fast. So these are a little bit different. They don't necessarily have to happen on bony prominences, but they can be skin changes with bruising. They also can happen very, very close to death. And they typically don't ulcerate. So that's the difference in these and perhaps a Kennedy ulcer. Um, the understanding is that these are they are researched, but they probably need to have a little bit more focus done on them so that we can actually distinguish why they happen in certain stages and not at others, and why they ulcerate and why certain ones don't. Um, so we'll go into, excuse me, into fungating malignancy now. Fungating malignancy, excuse me. Fungating malignancy. So this is where the fun pictures come up. A lot of times people will sort of look away here. So if you have a weak stomach, I hope not. But this is some very interesting pictures that we've been able to capture from patients over the years. And with their consent, of course, we're sharing these slides. So fungating malignancies are typically due to cancer. There's usually some sort of a nodular, a fungating growth coming from the skin through the epidermis. And it can happen just from the tumor itself, the primary tumor itself. It can spread through the skin, or it could be something metastatic. And I'll say from my own experience, typically I've seen more breast wounds that are fungating. I have seen a ton of wounds that are on the head and neck. But you'll find that these wounds are they're difficult to sometimes be around, if you will. Like you really have to have some thick skin and some a lack of olfactory senses to deal with some of these because they can be very smelly as well. So here, this next picture is a really significant we saw a few years ago. Kind of highlights everything that you would think you would see with this kind of a wound. So I remember this patient, a significant odor, a lot of exudate. It was very friable, meaning so anytime you really messed with that wound, they would bleed very easily. This is, of course, a very significant wound. They don't have to always be this big, but the ones that I've seen on the head and neck are usually pretty significant. So they'll be kind of cauliflower-like. They protrude through the skin, and sometimes they can be pruritic. They don't have to be, meaning they can itch. But you'll see a lot of necrotic tissue there. You can see some of the darker areas here. Those are more dried out. And then you can see some of the more sloughy areas. And then I don't remember specifically if this was calvarium, if this was skull, but I believe it was. But you can see the rolled edges, the ulcerations that happen. And then most often, especially when you see the odor that comes along with this, you'll get bacterial colonization, which is not that uncommon. It's not something that you necessarily need to treat. Once again, it's colonized. I said colonized for a reason. But you're really looking at this from a standpoint of, okay, I'm seeing a wound here, and somebody's going to come to you and say, hey, I don't know what to do with this, right? So we'll get into that here in just a second. So, um, we'll talk about a holistic approach here. And so I mentioned the goals of care are a little bit different when it comes to palliative and hospice care wounds, right? So if you think about how you're trying to take care of your patient, once again, with our straightforward wounds, we're looking for one goal and one goal ultimately, and that's to heal the wound up. With many of these wounds, especially these fungating malignancies, you're not necessarily going to heal them. You're certainly very always optimistic, I'll say, but especially in malignancy, you're not going to heal those wounds. So you want to think about what you can provide for the patient. You don't look at a wound like the one that I just showed and you think, okay, well, I'm going to heal that. You're obviously not going to. But if a dressing change perhaps is really complicated and it's really difficult, you can provide some relief there with the way that you do your dressing changes. You can provide some symptom management, um, provide comfort and reassurance because for that patient, a lot of times you'll find they've been living it with it for a long time. And so they may not even be aware of how disfiguring it is, but their loved ones probably do, right? So there's a lot of emotional distress that you may have to manage not only with the patient, but also with their loved ones and the people that wind up seeing them on a daily basis. So we'll get into this stuff once again here in just a couple of minutes. Um, so we have fungating malignancies and treatment tips. So once again, these are going to be very incurable. You're really going to try to support with some moist wound dressings and just try to make sure that because when those they do tend to drain a lot, and if they if the dressing gets stuck there, that can cause a lot of pains. You typically have nerve endings that are there. And so you want to try to give something that's absorbent, but not something that's going to trap too much of the moisture within the wound bed because this bacteria we mentioned, the colonization that occurs with fungating malignancies. If you trap too much of the moisture in there, then the bacteria are just going to go crazy and you're going to get an abscess or something really bad. So I've seen those a lot with breast wounds, and it's sometimes it's unavoidable, right? Because if there's a loculation under the malignancy itself, you're just going to be draining a ton of pus and you're just going to have to manage the drainage as best you can. So painful dressing changes, certainly not something that's easy to deal with. They should occur as infrequently as possible. Once again, you want to change it often enough to where you're not trapping too much moisture there, but you're also not doing it so frequently that you're causing so much pain to the patient, right? So there's a balance there that occurs. And I will say here on this point about the debridement, it's often not useful, and actually, in my experience, debriding malignant wounds is an absolute no. You should not debride a malignant wound. You run the risk of seeding tumor cells into the body, and it can cause further tumors, metastases downstream. So you absolutely should not be debriding a malignant wound. Antimicrobials can help. There's some topicals I'll mention here in a minute, and a few other modalities that can help you when you have a malodorous wound or a wound that looks like it's getting infected. Um, as we transition out of those few wounds that we just talked about, I'll talk about unavoidable nodes. And this is something that's relevant not just to patients with wounds, but patients without wounds. And I'd like to try to identify these early on because if you feel like somebody is having or heading down end of life, right? If they're palliative or if they're in hospice, you want to at some point have your provider, or if you're a provider yourself, leave a note on the avoidability of those wounds. This is significant, obviously, for those patients that are in nursing homes because those patients are so scrutinized when it comes to the development of wounds. And a lot of times, yes, we all know, okay, this patient wasn't eating well, they're non-compliant, they're incontinent, and you put all those things together, and you're like, well, obviously, this wound, there's nothing. We've done every intervention that we possibly can. And from doing all those things, we've educated, we've put the right surface in place, and yet still, because of a bunch of different factors, whether it be intrinsic to the patient or extrinsic to the patient, this wound's not going to heal, or they could even develop worse wounds. Or new wounds that they don't even have yet. So it's really important to try to identify those patients. We try to educate our providers in identifying these patients early on. But if you see one, and the provider hasn't really identified it because sometimes they're going a little bit too quickly and don't take a second to really recognize that something's changing and this may not get better or they may develop worse wounds. Pull them aside and say, hey, do you think this patient maybe meets criteria for an unavoidable? Just because we've done everything we can, and in spite of all of our efforts, they may have unavoidable skin breakdown. That doesn't mean that they end of life. They could actually be they may have a long life, but because of their compliance or because of their disease process, they may live a longer life, but they may have a potential for breakdown because they're there's just too many things going on there. So remember that if you have a patient that you may need some extra documentation on. So we'll go over some of that documentation. It's important when you're documenting on these patients to take a look at really the whole patient. You want to talk about the clinical condition. The provider should discuss, and I'll give you an example here in a second, but the provider should discuss what's going on with the patient. Are they at risk for developing pressure injuries? And if so, why? Is it because they're a paraplegic? Is it because they have cancer? Is it because they're mostly bedbound, and you've already changed the mattress, you've already changed the surface, or they're refusing to turn, any number of reasons, right? So clinical reasons. And then the interventions that you've done. Have you offloaded? Um, are you doing frequent turns? Are you using the right mattress? Are they sitting in the right cushion? And then you want to be able to have yourself or the provider really evaluate, okay, this has been 2 weeks. Skin is looking like it's getting worse, and we've done everything that we can. Is there a chance that this could be an unavoidable situation where there's patient's going to develop wounds or is developing wounds that we can't do anything about? And CMS actually recognizes this, and the approaches to this are very appropriate because not all risk factors are fully modifiable, or can they be addressed? Because residents have rights, right? Patients have rights. And so you can educate all that you want, and they still don't change their behaviors. This could be one of those situations where, whether it's malignancy, end of life, anything, you want to be able to put in an avoidable or an unavoidable note, excuse me. So based on that clinical condition, you should be able to put together with your provider a note. This is just kind of an example of a very good and thorough note that CMS would recognize and say, or the state surveyor or CDPHE would come in and recognize and say, okay, you took a full look at this patient. And you can see from this example, it's an end stage pancreatic patient, terrible intake, BMI is 14.2, rapid decline, bed bound, some of the things I mentioned, not very poor intake. And in this case, he's under hospice palliative. But even if they weren't under hospice palliative, you could still look at this patient and say, patient doesn't want to be hospice, doesn't want to be palliative, but we recognize that there's problems here. And so just, and then this is the kind of the critical component. They're both important. Both paragraphs are very important, but the second portion is you've got interventions in place. You put preventive measures in place. Further skin down is actually expected because of, A, B, and C. Your terminal condition, poor intake, they're not turning, so you have hypoperfusion. And then based on the overall condition, the wound is deemed unavoidable and consistent with the natural progression of terminal illness. Preventive strategies, of course, in your EMR, you're documenting that prevention was put in place and which measures those were. And so the focus moving forward then becomes what we've been talking about is to palliate, right? Not palliative care per se, but you're trying to palliate. You're trying to minimize the disease process or the symptoms of that disease process. So some could be pain, some could be odor, some could be drainage. So we'll jump to the next question here. I'll read this for you and then give you about a minute to take a look at it and answer. So what do you find to be the biggest challenge in managing wounds at the end of life? And as a reminder, if you want to receive credit, everybody is required per CUs to respond to the poll questions. So please try to answer. Okay. So a variety of responses here. I see um, pain and symptom control, the expectation and goals of care. That's a huge one. Preventing infection and odor, and then to decide when to stop aggressive treatments and lack of clear guidelines and resources. So certainly all of those I think are relevant. Pain and symptom control we're about to go into, and the rest of them here we're going to touch in a second as well. So um, once again, palliative wound care. Let's talk about priorities for a few minutes here. So, when we are approaching somebody to try to improve their quality of life, whether it's a symptom, trying to alleviate give some relief, you can apply this to anything. It doesn't have to necessarily just be cancer, end stage diseases, or anything like that. But when somebody is really looking for and understanding that the goal is not going to be to heal that wound, you're trying to do you've got to think outside of your I've got to fix this, right? You've got to get out of that mindset, which is really challenging to do. So you have to integrate yourself with a team, right? So your primary care folks, they're going to have to voice this as well because you all have to be on the same page when you're talking to a patient and their family and their loved ones about what is your expectation with this wound, and then having a realistic discussion with them about actually if that goal is achievable, right? Because if you're seeing somebody who's got a BMI of 14, chances of healing and alongside the other comorbid conditions that they have are going to be pretty low. So taking that to talk to the primary care and saying, hey, let's get on the same page here because this is what I'm saying. They've got a bad wound. We all need to be on the same page with saying this bad wound because of A, B, and C. We've done everything we can, but because of something going on that we can't control, this is likely to get worse. So having that understanding in your head is so critical, and it's such a like an antithesis to what we normally think of when we're trying to take care of a patient's wounds. So um, we're looking at symptom relief and comfort, I mentioned. So maintenance. Chances are you may not be able to let the you may not be able to stop the wound from deteriorating. So one of the things we talked about in the very beginning was the healing process, right? We're going to go into this in a couple of slides as well. Like when we talk about a wound and how it impacts a patient, sure, there's going to be a pain, there's a wound there, they've got to have dressing changes and so forth, right? But one of the things that people don't talk enough about is the actual psychological component of it, right? So when patients get wounds, more often than not, they're going to notice like, hey, I kind of smell bad, or hey, I've got a big bulky dressing on my leg or on my backside. And it's I don't want to go outside. I don't want to leave my room. So their quality of life actually gets impacted, right? So it's one of the biggest things that I think we have to think of as clinicians, is how do we keep them involved with their day-to-day lives as much as possible. So there's a lot of education that goes around with it. Um, and then there's frankly, there may not be something that you can really do because if there is a large fungating wound on the back of somebody's head, you probably want to cover that up so it's not as embarrassing for the patient. But that social isolation is very, very critical because there's a psychological component. You know, they stop caring, they stop getting involved with others. And why is that? And it could just be something so simple as educating those folks around them into understanding like, hey, this is a part of the process. Where it's not something that obviously anybody wants, but this is where we are, and we don't want them to become reclusive because their quality of life is already struggling as it is, and the further they go down psychologically, the more quickly it may lead to their demise. Um, so secondary goal, heal the wound. Sure, we'd love to say that that's going to happen. That may not always be the case. So wound maintenance, not letting the wound deteriorate. These are goals I would say of any wound, right? Especially a chronic wound per se. Is you don't want the wound to deteriorate, but like I said earlier, you may not be able to slow it down. If there's a lot of things going on and there's a lot of I mentioned the catabolic state. When you're taking an approach with a wound in a patient that's not in a palliative or a hospice state, you're looking at aggressive nutritional support, right? You're providing calories. We talked about the catabolic state. High protein intake can always help, but they may not be able to take any protein, anything extra. So you want to try to help reverse that protein energy malnutrition and reduce the amount of auto cannibalism, if you will, of your lean body mass. So supplements, vitamins, minerals, sometimes even appetite stimulants, and then early enteral nutrition is so key when patients have a lot of stuff going on. So, and then of course controlling the stress response, pain, hypovolemia, infection. Those are really, really critical. But in these cases where they are palliative or they're hospice and you're really looking, you may not even have an opportunity to do those things. So how then do we do the best that we can for these patients, especially in terminal patients that have uh, already passed that stage of where these interventions could have maybe slowed things down a little bit. So I mentioned one of the slides that I wanted you to kind of think about, right? So this is one, if once again, you can look at this again, this video again, or this recording again on our YouTube channel. But if you want to write these down, these are really important because you're going to get at some point, if you haven't already, you're going to get at some point like, okay, we have this major wound here. We don't know what to do. This is a pancreatic cancer patient. These are the things that's going on. How do we approach it? And you know in your head, this wound may not heal, right? And so the components that you really need to focus on, and like I said, it's so counter to what we think about when we're trying to heal a wound. So you want to control odor. You want to control or prevent bleeding. You also want to control the exudate, and you want to be able to manage pain. Itching is also another significant component, and then the cosmetic side of it is something that probably can't be overstated. So these should be your six objectives. Like if somebody comes to you and says, "Hey, what are we going to do here?" And you have to be, if you know for sure, and you've talked to your primary care and your wound care provider, and you say, "Hey, we're not going to make a lot of progress with this, but we want to try to put this patient in a position where their quality of life does not go down significantly." So here, these are the six things you should try to remember of like an approach. And so we'll go through each of these here in a second. So controlling odor, there are a lot of modalities that we can utilize to help control odor. I mentioned the psychological impact, the embarrassment. There's a lot of social isolation that can happen. And that odor may be so significant they may not want to even eat, right? So, and if it's something that's significant, they'll feel self-conscious about it. But it's often described as a symptom that is most detrimental to a patient's quality of life. Now, causes of the odor, important to know the why before you know what to do about it, right? So increased skin breakdown will lead to necrotic tissue. The dressings then will become really saturated and they will hold a ton of bacterial byproducts. So the ones that you think about that produce the most significant odor are usually the anaerobic bacteria and the gram-negative microorganisms. They're typically present in the necrotic tissue and they'll thrive a lot of times without oxygen. So in interventions, there's so many nursing tricks I've learned over the years that can help. Once again, fungating malignancies, we're not debriding. We're not going to debride those. We can cause tumor seeding. We're not going to do that, period. You can wipe away tissue if you need to, but we're not going to do any kind of sharp or surgical debridement. That should be left in the hands of a surgical oncologist in a controlled OR setting. But if you have access to it, Dakin's very effective. Yes, it is sodium hypochlorite. It is bleach, and so there is an odor component that comes with that. Acetic acid, also very good at neutralizing, especially those patients that have Pseudomonas colonization. So those are two sort of medical grade things that you can do. But there are other things, like I said, over the years, nurses are very crafty in coming up with solutions for these things. And kitty litter, I've seen that under a patient's bed. Not suggesting that you put that into the patient's wound. Please don't take it as that. Vinegar, coffee beans, potpourri, candles, things like that. And so we'll go over some of the antimicrobial dressings. But one of the other effective things that I've seen over the years is using things like metronidazole. Flagyl is a very effective uh, uh, medication. And so I say that hesitantly because when most facilities, if you're going to use metronidazole or Flagyl, there are regulations about when you can use it and break it apart because it's not maybe something that's listed on the MAR that you can actually do. So you have to make sure that you get an order from a provider to say, break the capsule apart, and then you can put that. So out of those things that are on that list, the only things you can put in the wound bed are Dakins or acetic acid and Flagyl. So honey gel you can also use, but the other things are more just the external deodorizers like we talked about. Um, so Flagyl you can find as a powder. You can also get it as a gel. But it does have to actually help if you think about the actual uses for metronidazole with things like some GI complaints and stuff like that. It can actually kill bacterial infections or at least stabilize them so that they're not becoming so prominent. And because that can lead to a ton of bad odors. And crushing the metronidazole tablets, which is probably the most common way you're going to find it because Flagyl gel is a very expensive component. So you have to make sure this is either written by a provider or prepared by a pharmacist. So just be careful when you're utilizing that to make sure it goes along with the guidelines of your facility. Um, Charcoal. I mentioned I've seen stuff under beds, charcoal, kitty litter, potpourri, all these things can kind of help. And you'd be surprised at how effective charcoal can actually be. Now, they actually have dressings now that have charcoal impregnated dressings. So they can basically pull out some of that odor. And you can use these with your antimicrobial dressings. And you can use these in maybe a primary or a secondary dressings. But these should be changed every few days. Once again, the odor can guide that a little bit. Um, Pain can obviously guide that a little bit too. So important to remember those things. Um, Bleeding. So fragile blood vessels, especially around a wound bed, it's usually caused because there's a lot of inflammation around that wound bed. So you can even just wipe a wound and all of a sudden you've got bleeding for days, right? So really important to be careful with some of these um, more malignant wounds. And obviously you also have patients that are on anticoagulants. But you'll notice, like I said, minor trauma can result from just basic wound care. So you could take an adhesive dressing, pull away some of the epithelial layers, and then you've got bleeding that you have difficulty controlling. So sometimes that can also that can also happen from excess moisture. Some ways to think around this. One of the more common ones that I'll use are those mineral oil impregnated or adaptics that can basically, or Mepitel or Versatel if you have access to those because they can basically lie on the wound bed. They have mineral oil inside the actual gauze itself. And then they may not be foolproof in terms of depending on the amount of drainage, but you can pull those back gently and it won't cause as much tissue trauma as, say, just like a dry dressing would. So, Telfa is also very effective. And pressure for controlling bleeding that can also be super effective and might be your only modality sometimes. So silver nitrate also one of those things that your provider will probably have to do. And so there's all sorts of things that you have to think about when you're changing a dressing. And if you know that the dressing is or you know that the wound is going to bleed, you need to be prepared for that. Controlling exudate. This is once again, we're going down that slide where we had the six things in there. So we just finished up with the odor and the bleeding. Now we're going to go to controlling exudate. Sometimes these can be very, very difficult to control. So I've seen many malignant wounds and many end-of-life wounds that are just control that are so much exudate. And all you want to do, especially with those patients, one, you want to try to prevent infection, right? So two, then you want to control any exudate that comes out. So you have to make sure you're changing it frequently enough so that the moisture isn't just sitting there. We talked earlier about the bacterial byproducts that can sit in the wound. And so if you're not changing it frequently enough, then that bacterial byproduct can turn into a bigger infection. And it's no longer just colonizing, it's now you're dealing with something much worse. So it's a very big balancing act that we have to play when looking at these. And what I'll typically do with these that I don't know how long the dressing is going to last. Is it going to last for a day? Is it going to last for 2 days? Is it going to last for 3 days or a week? I don't know. And you may trust or may not trust the historian that's giving you the information. So what I like to do is to try to err on or once every 2 days. And then if I feel comfortable at once a day, then I'm going to move forward to once every 2 days. And then if that looks like it's okay, more on the side of caution and do it more frequently in the beginning. Next week, when you come back, you can expand that a little bit if things look okay. For those of you that have been on these calls before or these webinars before, this is probably an image you've seen before. We like to use it just because it has a lot of things there. The greenish drainage, we all know Pseudomonas and things like that, acetic acid. But you can see the drainage needs to come off of the patient, right? So when you are able to, and you're able to control that component of it, minimizing the dressing changes once again. One, it can help with patient pain and dressing changes and the frequencies and stuff like that. But try to minimize it. But sometimes you don't have a choice. If it's happening to happen to happen, it has to happen more frequently, 2 to 3 times a day. That's what we're going to have to do. So pain, this is a big component for me as well, pain assessment. And I'll go off on a quick soapbox for a second here. Um, Pain management, there are some phenomenal pain management people out in the community. Especially I mentioned palliative. If patients are on palliative care, they can still go see a palliative care provider, or they can still go see a pain management specialist. But some of the best that you don't even realize are so good at taking care of pain are your palliative and hospice providers. They are some of the best when it comes to controlling pain for patients. Their skill set, and if you ever have a patient that you don't know how to control their pain and you're struggling with it, find one of them because they are super smart in terms of knowing the morphine equivalents and how much actually you can give somebody. We're all fearful, of course, of overprescribing and things like that. But sometimes if you have a patient who may be terminal, and you're having trouble controlling the pain, those palliative and hospice providers are quite experienced in terms of controlling pain with other modalities. So use your pain assessment tools. The FLAC, of course, is important, and just having some kind of a guideline for how to assess pain properly. And the other thing I'll say about that on another soapbox is skin subs. And this has been going on for several years now. Skin subs, especially there are a lot of groups out there that are targeting patients that are on hospice, and they go and they tell their family, if we put this skin sub on, it'll actually decrease the amount of pain that your patient is in, or your loved one is. And they prey specifically on hospice patients because it's just very, very nefarious. And so if you see folks that come in and you have a significant wound and they say, oh, well, you've got Medicare Part B coverage or you've got whatever coverage, we can actually help you with this because our product will take away your patient's pain. Absolutely not true. The only thing that they're doing is they're decreasing the frequency of the dressing change. And because those nerve endings are not getting disturbed as much, they're coming in and they're applying a product there it's completely unethical, but that's another topic for another day. So don't let your patients get pulled into that. You have to make sure you educate them. We can certainly decrease the frequency of dressing changes. Those dressings cost tens of thousands of dollars. They will not heal that patient's wound. And they truly are not actually relieving any pain. They are just there because they're able to decrease the frequency of the dressing changes. So end of my soapbox. But analgesics, once again, I mentioned going to a pain management clinic or finding a hospice or palliative nurse practitioner, or PA, or physician that can take care of those pain and help you guide you through those things. So some other things, the peri wound, as those wounds get deeper, the nerve endings are not as frequent, and so you don't see a lot of pain there. But on the surrounding area where there are more nerve endings, that peri wound can get very painful. So make sure you protect the peri wound a lot. And then once again, I've said it a few times today, minimize the trauma with the dressing changes, and reduce any kind of frequency if you can. So we'll jump to the other question here. What barriers do you face in delivering palliative wound care? So just pick one choice here. So is it a lack of training, limited resources, time constraints, family expectations or other things that we haven't thought about. Okay. Um, so the two highest ones were lack of training and family expectations. Um, I would say that's certainly the first one is why we're trying to help educate today. Family expectations are really, really hard. I mentioned this earlier about having discussions with, the primary, and having everybody on the same page. I think that's really important because a lot of patients aren't really willing to accept, or patients' families are not willing to accept that there's nothing more that can be done for this one. And once again, it's very counter antithetical to what we typically do when we're talking about healing a wound. It's such a different mentality, and you kind of shudder when you think about saying that to somebody. But sometimes there really is not much that we can do for them. So managing those expectations and just being honest with them, right? I'm sure everybody on this call is, an ethical person and not wanting to mislead somebody into thinking that, hey, yeah, if we do this, this will actually help, heal the wound. When you know in your heart that the wound is so significant, you're not going to be able to heal it. So, um, okay. So moving on to some of the final things on that six panel thing. So itching, so many triggers. Histamine is usually the biggest trigger. Sometimes can be caused by some of the opiates that we actually give as well. Skin irritation. Some ways to counter the itching. You keep the area moisturized, especially here in Colorado, if that's where some of you are. There are some pharmacological modalities that your primary care will have to work on with implementing if those are appropriate. Things like wool clothing are also very can be triggers. And then keeping their nails short, that makes a big difference too, because you'd be surprised the longer nails that they have, the more they're going to itch. And obviously the bacteria that can accumulate under your nails can also lead to more infections too. So keep those nails cut short. Cosmetics. So once again, a thing that we don't think about. Maybe we see it, but you don't think about the embarrassment for the patient or for the family sometimes. So something that should be taken into account. Bulky dressings can sometimes be a benefit. But if you can minimize those, especially if you're not having to control a lot of drainage, the less bulk, the better. And then consider comfort and fitting underneath the clothing. Communication. This is critical. Having realistic expectations. And then obviously, it's really challenging sometimes when you see something that you haven't seen before to try to minimize when you walk into a room and you don't know. Nobody mentioned that they have a giant fungating mass coming out of the back of their head. You've got to be able to check that before you walk in the door and not have a reaction. Whether it's a scale or a fungating wound, so important because those patients, those family members, they feed off of your response and your reaction. We talked about unavoidable notes. These you can look up online on how to properly document when there's an unavoidable issue. Making sure you're doing wound assessments and the dressing changes and the frequency and why those dressing changes are appropriate. Also very critical. We're most of us in a nursing home environment where everything that we do is highly scrutinized. So make sure if you did it, document it, or otherwise you didn't do it. So communicate with family, friends, caregivers, and all those things. So that wraps up our talk for today. I will let you know that we have these monthly. The upcoming webinar is a pretty big topic, a little bit more focused on pressure injury and pressure injury prevention. It's our most frequently requested topic, but it will be next month on a Tuesday rather than on a Wednesday. So please note that on your calendar. If you're normally expecting it on the first Wednesday of the month, next month it will be on the first Tuesday of November. And if you need us for anything, ProHealth, we are obviously in several states, especially in Colorado, but several states around the country. You can reach out to us, and we also have a wound prevention program that we're quite proud of. Feel free to reach out if you have some concerns. We can really help risk stratify your patients in your facilities. And that's it. So hopefully left a few minutes there for questions. I think exactly 5 minutes. So
All right. It looks like Alisana is asking what causes fungating malignant wounds.
So great question, Alessana. We mentioned this earlier. So fungating malignant wounds, you'd be surprised at the lack of health IQ that some communities have, right? So that can be a central issue where there's just not a lot of education in certain communities that will allow either a patient or their loved ones to allow a wound to progress to the point that they become fungating. And the second component is also fear, right? So fear can lead a patient to, know that something isn't quite right, but yet they're scared to go in and ask about it. And the next thing you know, I see that a lot with breast wounds that are malignant. Cancers in particular, they're going to grow. And if you don't slow them down or stop them or have them treated, they're going to grow and they're going to grow and grow and grow. And so depending on their location, they'll eventually go through the skin. Not all cancers do, but when they do, it's because they've been left untreated. And so, two components. One is probably the biggest one, I would say, is either fear of finding out that something's wrong. I have loved ones in my own life that are scared of going to the doctor, and so they don't want to know if something's wrong, and they just kind of like put it off and say, okay, we're not gonna worry about this because I don't want to hear any bad news. And the second thing is probably a lack of education.
All right. And then this next one, I think, is one of the ones that I hear most when it comes to palliative wounds. How do you know when it is appropriate to debride? There's always people like, oh, that person's on hospice, they don't want to do treatment, but how do we know when it's actually appropriate to debride?
Yeah, that's a very good question, a really good question, and one that I think takes time and understanding, not necessarily in terms of the experience level, but time with the patient, probably more than anything else, and understanding goals of care. Um, with a hospice or palliative patient, you have to understand that, when I think I even go through this fairly frequently with my patients as well, is if I have a hospice or a patient that is not likely to heal, are you doing enough for the patient with just a simple dressing change to keep it from getting infected, right? That's usually where I draw the line. If I feel like patient is progressing and because of such and such thing, if I do one debridement, will I get ahead of it in some senses, right? Will that buy me 6 weeks or something like that, or 3 weeks or whatever it is, so that I don't have to worry about this patient becoming septic from the amount of slough or the necrotic tissue that's there. Um, and so that's a line that you have to have a discussion with the patient or their loved one who's taking care of them. So you can say, hey, this is what I'm seeing. You've got some tissue there. I'd like to remove it, but I'm kind of concerned that if I don't remove it, you get an infection from it. But if I do remove it, this isn't going to heal the wound. And so you have to have that discussion, like risk versus benefit. And it's a very I'll say it's a blurry line, not intentionally, but because you have to have that discussion with the family. And there's no definitive line that says, okay, when you see this, you have to debride, or when you see this, you don't debride. It's more important to have that conversation with the family, and with the patient about what you're trying to accomplish. Sorry, I hope that answers that question.
Definitely. I think we might have time for one more. What are the most common gaps you see among clinicians in palliative wound care, and how can they be addressed?
Most common gaps I see in palliative wound care, I think would probably be the education component. That's probably the most significant thing is wanting once again to turn off that mindset of trying to heal a wound. There's a global understanding of what the patient is and where they're going. Goals of care, somebody alluded to this earlier. Goals of care are so important because if you don't sit down and say, family, this is what we're dealing with. Where do you expect this patient to go? If you don't have that conversation with them in the palliative world, especially in the hospice world, especially if you don't have that goals of care conversation, you specifically got to talk about wounds, right? Not just about, okay, well, you're not just talking about a most form, you're talking about not just CPR and those things. You actually specifically have to talk about the wound itself. And so one of those, and those conversations can change because initially it may just be a simple the beginning of a Kennedy, and then 2 weeks from now it all of a sudden has slough in that wound. So how then do you have that conversation, and do you understand that, okay, now that there's necrosis there, we may have to do something different? So the education is probably the biggest component, that I've seen where there's a deficiency, and spending that time with the family to explain to them, this is what's going on. This is what I see. I could be wrong. Hopefully, I'm wrong that this is not a wound that we're not going to be able to heal, but there's a chance that because of A, B, and C, we may not be able to have that. And so that's probably the education, and then probably that goals of care discussion. Those are probably the two things that I would say need to be addressed more often.
And I think that's all of them.
Okay. Well, thank you everybody for joining today. You know how to reach hopefully all of us. If you don't, that info@prohealth1.com. We'll get back to all of us with any other questions if you think of anything afterwards. And we'll see you all next month on Tuesday, November the 4th for pressure injury prevention.